Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Professor Christophe Mathoulin from France. Early in his career as surgical trainee, Professor Christophe Mathoulin was the recipient of the prestigious Gold Medal Award at the Hospital de Paris, which earned him the opportunity to join the renowned practice of Professor Thierry Judet. He transitioned to the Department of Orthopedic Surgery at the Pinal Hospital from 1987 to 2002 under the leadership of Professor Thierry Judet, where he began as chief resident and later joined as faculty for the next 15 years. In 1988, he also became member of the Institut de l'Allemagne, premier hand center in Europe, developed by Professor Raoul Tubiana and Professor Alain Gilbert. He currently remains as the honorary lifetime president of the Institute of de l'Allemagne. Professor Mathoulin is an orthopedic surgeon with specialization in hand and upper extremity surgery and microsurgery. He has contributed to more than 300 peer-reviewed publications and is founder of the European Wrist Arthroscopy Society. This society continued to evolve to become the International Wrist Arthroscopy Society, where Professor Mathoulin is currently an honorary lifetime president and founder. As founding president of the International Wrist Centers and IRCAD IWC, he is currently active with the IWC at multiple prestigious IRCAD centers worldwide, which includes France, Taiwan, Brazil, Rwanda, China, United States, and India. So today it's my great honor to introduce you to Professor Christophe Mathoulin from France. Over to you, Professor.
Hello, everybody. Nice to share with you this long experience we had in the practice of the wrist arthroscopy. And thank you to my team and my partner, who were my student, Lorenzo, Alam, and Mathilde. We worked all together to the International Wrist Center in Paris. So the history of wrist arthroscopy, of arthroscopy, started in 1919. You see, it was with Takashi in Japan. We were the first professor and the first man to adapt endoscopy to the knee joint. Philippe Crocher in USA started in 31, and Watanabe in 72, in fact, is the first man who put a scope in all joint, included the wrist. At this period, two persons were very important in the wrist arthroscopy, Empfling in Germany, but unknown, and Thierry Whipple, who can consider our godfather in wrist arthroscopy, because he developed the idea that we don't have to use the wrist arthroscopy only for the diagnostic, but also for therapeutic. During this period, 80 to 90, we were a few to use the wrist arthroscopy, and it was, of course, almost or every time to make a diagnosis. Pedersini and Lucchetti in Italy, myself with Philippe Safar in France, Dotel and Bohr in France, Fontes in France, Luc Desmet in Belgium, Tommy Lindo in Sweden, and we can add Doi in Japan too. The first course has been in 86, and if you look carefully, you can recognize here Gary Pelling, here is Thierry Whipple, Leo Sterman and Mark Barat are there, and it was a majority of future great wrist arthroscopy. In the 2000, we decided to create a group. It was the first society dedicated to the wrist arthroscopy and to the wrist, in fact. We call that the European Wrist Arthroscopy Society. And, you know, it was really complicated to have a society, scientific society dedicated to the wrist, because the orthopedic surgeon and the hand surgeon was convinced that the wrist is a part of their field of experience. And with the trick to add an A for arthroscopy between the wrist and society, we can develop a real wrist society. So the very important thing is, in fact, that we managed to share experience between different surgeons from different continents, and you can recognize here PCO, Jean-Ragnar Zvector, Toshi Nakamura, and it was very incredible because, and I'm very proud of that, all the researchers accepted to share their experience and to work together. And logically, we became an international society. If you see on this picture, you have Max Halle from Germany, Tyson Cobb from USA, Nicole Gidman from Switzerland, Jean-Ragnar Zvector from Norway, myself, Wendong Shu from China, Thierry Whipple from USA, Heather Bohr from Germany, and Henker from Netherlands. So it was a very real scientific society, international scientific society. So what is the interest of the wrist arthroscopy? Not only for the diagnosis, of course, it's essential, but step by step, we understood that we can perform very nice intervention operation without happening in a real mini-invasive procedure. And you see, when I celebrated with my team, my resident, my 3,000 cases in May 2015, 8 years ago, it was an arthroscopic capital lineage fusion. It was not nothing. I have tried to see what was my indication after 4,000 cases, and you see that I use for diagnosis only in 1% of cases. But it's interesting to keep in mind that when I do the same work for the 2,000 cases, the isolated diagnosis was 2%. So it means that since the first cases, I never used the wrist arthroscopy for only an isolated diagnosis. It's always for to perform a surgery. And you see that, of course, intrinsic ligament tears are the majority of cases, but the fractures, the second, arthrolysis, ganglion, arthrosis, ganglion excision, and many, many other indications. So the ganglion resection, you know, we have to separate the painful ganglion and the unpainful ganglion. And when we have a cosmetic normal ganglion, it's very interesting to use this technique, very simple, with two approaches, radial midcarpal, ulnar midcarpal approach for the scope, and the transcystic ganglion approach described by Elias Terman. And you remove easily the dorsal capsule in front of the area, the origin of the ganglion. After that, you put outside and you transform your arthroscopy in endoscopy and can remove the wall. It's very interesting. Excuse me. Sorry. So for the volar ganglion, it's the same. It's very interesting because you don't have to go outside. So don't forget that the radial artery is in front of the ganglion. So if you stay inside the joint with your suction pumps, you can aspire the wall of the ganglion, and you don't have any damage with the artery. For the intrinsic ligament tears, we have the TFCC tears and the scapholine tears. Alain Gilbert, my mentor, told me that for him, at the beginning, when I started the wrist arthroscopy, for him, the wrist arthroscopy was useful for two indications. It was a long time ago: TFCC tears and distal radius fracture. He was right, but not sufficient, of course. We have a lot of other indications. So you see that here, the summary of the different procedure, the peripheric suture, the large dorsal dissociation, the foveal reattachment, or the tongue complete reconstruction. So thank you, my friend, Tommy Lindo, Andrea Tsai, Paco Pinal, and Toshi Nakamura, because thank you, because you accepted to work together. And thanks to you, we modify completely the understanding of the TFCC problem, with the distal tear, the proximal tear, the complete tear, and of course the non-reparable. And in this different stage, we can perform different repair. Here is a dorsal detachment, and you see with in-out suture, we obtain a very good repair, we have very good attachment. And look at this repair here, 6 months after use the absorbable suture, you have to control for other reason, and you see that the TFCC is perfectly intact, normal. You don't see anything, and it's just amazing for us. The foveal detachment could be isolated or associated to a lateral lesion. The pull test of the GOST sign by described by Fontes and Atsay are very interesting. The technique, we put an anchor and we use a small direct foveal portal as described by Andre Atsay. And in fact, you put an anchor and you do a suture with a special trick you can find in my book or in WebSurg video. It's very interesting. So the second very great achievement we obtained with the scaffolding, with the arthroscopy, is to understand that the scapholinate was not what we believe at the beginning. It means this arch of soft tissue, because if you look carefully this area, you see that the color is not exactly the same as the other part of ligaments, and it means that it is an unvascularized area. And during a long time, we repaired that by open procedure. It was a disaster. And look at here, you see here is stage 4, and look at the on-site click of Watson, you can see, and you see with the scope, we can pass between the scaphoid and the lunate through the damaged scapholinate ligament, and it changed everything. We understood also that there are not an arch of ligament, but 2 ligaments, a dorsal scapholinate ligament, which is very important, and volar anterior ligament, and something in the middle, the proximal part of the real anterior scapholinate ligament is not useful, in fact, and we can pass through them. Then arthroscopically, you see this case with a small instability. We see that the ligament is intact, but there is a detachment between the dorsal capsule and the dorsal scapholinate ligament. And here is a normal aspect. And in fact, thanks to the wrist arthroscopy we described a long time ago, the dorsal capsuloscapholinate septum, and we developed a technique now. Everybody accepts the principle of the technique is just to restore the anatomy between the dorsal capsule and the dorsal scapholinate ligament, which is the most important part and the key stabilizer of the scapholinate couple. So the principle of the technique is to pass 2 sutures through the capsule and through the remnant part of the ligament. Of course, you need to have a remnant part attached to the scaphoid. If not, you use an anchor and you put the anchor into the scaphoid. And after that, you made the knot outside, you pull the knot, which stays between the both bone and in front of the remnant part of the ligament, and you can fix the second knot. Of course, you can fix scapholinate, but step by step, time by time, you discovered that it was not necessary. And in my practice now, it's less than 5% of cases. For the distal radius fracture, you imagine how complicated is it to, by open procedure, to reduce this kind of die punch fragment. And arthroscopically, it was a long time ago cases. And you see at this period, we don't have this beautiful plate we have now. And I used some cow wires to stabilize the central fragment. And we obtained incredible good result. My friend Paco Pinal described the intra-articular osteotomy, which is very convenient for the patient because we have just to open outside the capsule. We don't open the capsule, we can reduce, control arthroscopically, and put a plate to fix the reduction. The displacement scaphoid fracture is a very good indication. And you see here, you reduce the scaphoid by different internal maneuver, and at the end, you put the car in a scaphoid, in the reduced scaphoid. I use the probe to maintain the reduction. And when the car is inside the both part of the scaphoid is stable. And after that, you have just to put your screw and to control the radiocarpal joint to see that the screw is well placed. The steroidectomy is very essential in the left wrist or the right wrist. It could be isolated or associated, and it's very interesting because you don't have to open. You know, sometimes in isolated cases, you imagine the hard lifter, the athletes who have this kind of problem. You enter with the scope, outpatient basis, you remove that, and the guy can retrieve a normal range of motion the day of the surgery and retrieve the training and the competition after 3 weeks. It's just amazing. The distal ulnar reduction is very important because you know that sometimes you can have, of course, congenital long ulnar, but very often when you reduce correctly the distal radius without plate, you obtain, because there is a sand in the metaphysis of the radius, you have an inline decreasing of the size of the radius. The ulna became too long, created a hole in the central part of the TFCC, and after that, at the contact with the lunate and the ulna. And if you continue, you can have a tear of lunotricutural ligament. So, of course, the right indication could be the radius osteotomy, but very often the patient are whole, and it's a complicated procedure. And arthroscopically, you enter into the joint, you increase the central perforation of TFCC because we know that there is no importance of stability, and you remove step by step the ulnar head. But don't forget that the ulnar head is not completely spheric, and it means you have to perform pronation and supination movement. And sorry, I have to return. Sorry. Yes, and you have to perform pronation and supination movement in order to remove every part of the ulnar head which can have contact with the ulna. And you see here, you turn, and at the end, you remove step by step. And at the end, we obtain that I call oblique helicoidal osteotomy, like that, you know, because it's absolutely impossible to perform that with a normal straight osteotomy. And the most important is we keep intact. You see here the ulnar head in the radius, here the sigmoid notch. We keep intact the sigmoid notch and the cartilage. It means that the patient can use the wrist the day of the surgery. You don't need immobilization, and you have to compare this technique to the ulnar shortening osteotomy or distal radius corrective osteotomy, which are very more complicated. So we have a lot of other techniques. Sometimes you cannot treat the proximal pole non-union. They are necrotic, muscleized. So arthroscopically, you can remove the different pieces, and you put the implant, which is a pyrocarbon implant, a HAPC implant, and which retrieves the right place between the scaphoid and the lunate, and obtain a good range of motion. It's a free implant. And you see this case operated 20 years ago with the final result, no scare, good strength, good range of motion. And it means that I call that waiting therapeutic option at the beginning, but now we see that it is a real therapeutic option, very essential and very good. So look at the numerous other indications, the STT implant, CMC joint replacement, with implant or with tendon interposition, the thoracic procedure, the interposition, partial bone fusion, synovectomy, carpal bone resection, TFCC fibula repair, intra-articular graft, cartilage defect, foreign body, etc., etc. Our inventive colleagues every day invent new procedure. So take care, because the wrist arthroscopy is not to play, is not a game, is not completely safe. And we perform with Caroline Leclerc a survey of more than 10,000 cases, and you see the distribution according to the states. It was very interesting to see that we have the difference of indication according to the surgeons who use regularly the wrist arthroscopy at this period or the other, and what was a complication. We describe a complication as an unfavorable event directly or indirectly linked to the technique of wrist arthroscopy. And it does not include secondary failures linked to the application of the technique. It's important. So we have serious and beginning complications. The serious is a lesion of tendon, nerve, artery, and cartilage, loose body requiring arthrotomy, hematoma, compartment syndrome, arthritis, wrist stiffness, failure to achieve the procedure, the compartment syndrome, etc., etc. The beginning, in the contrary, is a small cartilaginous lesion, transient nerve lesion by neuropraxia. Take care to the system you use for the traction. Loose body, nerve requiring arthroscopic, spontaneous resolutive problem as local swelling, superficial sepsis, etc., etc. Wow, big surprise. We had 6% of complication, and the majority, 5%, are serious. So it was a big surprise when we analyzed the survey. But the most interesting thing is to compare the difference between surgeons. You know, the majority of cases are from the surgeons, the 8 surgeons. I was included in this surgeon with more than 600, and you see that there is 3.7% of complication. The surgeon with less 600 is 10%, and the surgeon with less 100 is 14%. Wow. And it's according to the number of wrist arthroscopy by year, you see less than 25% is 19%, and less than 5 years of practice is 18%. Whoa. And if we had the boss, we obtain 1 complication on 2. Don't be discouraged, because it's not my aim, but it means you need, there is a learning curve, and you need to have a practice. And it's why we developed the wrist arthroscopy courses on Fresh Corps in a different part, of course, the HIRCAD. And we have funded recently the HIRCAD AWC courses with the help of Jacques Maresco. And we have free places until now. It was in Strasbourg in France, in Taiwan, Lukang, and in Barretos in Brazil. And we have regular wrist arthroscopy course, very convenient to for the training. But look at all the other courses you can find in the world, with the help of IWAS and APWA, and you have the possibility to train yourself. And please go to this course. It's very important if you want to start the wrist arthroscopy. And if not, you can have and visit different service. And IWC offers you a lot of fellowship in different parts of the world. And you can visit colleagues and pass between 1 to 6 months. And it's very convenient because it's the second part. So you see the course, it is a 6th course in China, and we perform this kind of course everywhere in the world. and we train currently more than 1,000 surgeons a year from 37 different nationalities. And if you want to have information, you call, you visit the website iwc.org, which is a very important website. You can find a lot of information regarding on the wrist arthroscopy, not only the list of the course, but also you can have a link with a different society dedicated to the wrist, APOA, LAWA, IWAS, etc., etc. You have the wrist database camp, which can allow you to obtain credit by formation. You have the link with WebSurg, and WebSurg, you can have a lot of video and conference dedicated to the wrist arthroscopy or wrist surgery. And you have, of course, link to the ebook, which is my book is not completely finished now, but it will be a book with different techniques updated regularly, very helpful for you. So keep in mind this website is essential for the wrist surgeon. So Kenji Takagi told us that I'm sure that the chapter on arthroscopy will appear in the textbook of orthopedic surgery in the future. Yes, of course. Of course, we have the book dedicated to the technique, but we have different books published with EWAS and IWAS. And we have the Journal of Wrist Surgery. I founded this journal 11 years ago with the help and the advice of David Slutsky, who was president of the American of the EWAS at this period. And Toshi Nakamura sent me yesterday that we obtained 0.7 in index impact factor. It's very important for our specialty because it's almost the same as the Journal of Hand Surgery. So we are very proud, and we have to continue like that. So the prospect, of course, we described the new pathology, so the proximal avulsion of radiocarpal capsule. We can see that when, you know, in for example, the golf player will stamp the ground, and you can have a big chalk of all the carpers, and you have a detachment of all the dorsal extrinsic capsule from the intrinsic ligament. We thank you, PCO, because it described a very fantastic technique for the treatment of scaphoid non-union, and for me, it changed everything, particularly for the proximal pole fracture. And I can tell you that until now, I never had non-union of the treatment, a failure of the treatment of proximal pole non-union, which is an incredible surprise because we didn't know that. So we describe a new fixation because with the arthroscopy, we see that inside the joint, we have the trichotome, the lunatome, and the proximal pole at the same plan. So it's more logical to fix the proximal pole non-union treatment with a scapholunate fixation than with a complicated screw. If you place it by the proximal pole, you can destroy it. If you place it in retrograde position, it's complicated to obtain a good fixation. With this fixation, you have the scaphoid, the area of the graft, the proximal pole, the joint, and the lunate. So it's very essential, and we obtain good union in very short cases. With arthroscopy, we discovered a new lesion also. Look at that, it's Mark Barat. We were to Shanghai a long time ago, and he cleaned the synovium in the front of the joint, in the mid-carpal joint, and we have seen this area. In fact, you see that it is here a key point with the junction of the radioscaphocapitate ligament, the long radial lunate ligament, and the capitate ligament. And when you have the destruction of this capon, it is a cause of the palmar mid-carpal instability. So we can treat it arthroscopically when we have the chance to make the diagnosis. The interposition, I love the tendon interposition. It's a very beautiful technique. I described that during a course in Taiwan a long time ago. I told you the story because we have the time for that. During this course, I performed some live surgery, and my colleague from Taiwan told me, you have a beautiful case of dorsal ganglion. So for me, dorsal ganglion, 5 minutes of surgery. I can train, I can last 20 minutes, 30 minutes, explaining something is very good. And when I arrived to see the patient, in fact, it was not a ganglion, but it was a horizontalization of scaphoid with a complete scapholinate dissociation. So we have to invent something. So I asked him to reverse the palmaris longus, and I placed it not exactly in this way, but it was the principle of this technique to place a tendon between the two defected chondral change area. And I had the surprise 6 months later when I come back for a new course to see the patient and to see that he was very well and has no pain. And we perform an X-ray and we see the good result. So I developed this technique, and you see one of patient, you need to have a stage 2, or it means cartilage intact in the radial day. So the classical indication in this case was a four-bone fusion of first row carpectomy. So it's a proximal row carpectomy. It's a PT, and look at after 6 years, I perform a steroidectomy at the same time, and you see we don't stabilize the scapholinate. Of course, we can repair it, it's too late, but we obtain a good stabilization, and the patient is really happy. So the arthroscopic bone graft of the lunate ganglion, everybody knows the complexity to treat the lunate ganglion, the painful lunate ganglion, of course. By open procedure, you have to pass by a volar, large dissection. You cut the volar ligament, the volar extrinsic ligament. It's very complicated. Arthroscopically, we discovered and we understood that the interosseous ligament, the proximal part of what we called before the scapholinate ligament, is unuseful. So you can pass through directly. You can reverse the ganglion and fill it with the graft, and it's very easy and very beautiful. So the future now, you know, a new technique, new process. Our colleague Lorenzo Merlini in Paris used the autocart technique, which consists of making a paste of cartilage taken here from the ulnar head mixed with PRP, then placed in the cartilage defect, held together with fibrin made from the patient's own blood. And I received 2 days ago the first image from the view. It's very encouraging. And maybe we can do better with the stem cells, because it was already used for the knee with a great success by a Malaysian colleague. And the arthroscopy is ideally suited to the use of the stem cells for the replacement of cartilage destruction in osteoarthritis by preparing the destroyed area receptacle, and probably it will be a great help in future. So we can finish with the magnification of the gesture by robotics. You know that in INTRAARTICULAR we work with the robots. The telemicrosurgery already exists and allows very small vessel suture. And the economic of the workstation, the multiplication and increase of the precision of gesture could be a great help, but until now it's not well developed. But you know that Arthrex developed the nanoscope, which is a flexible one, and maybe we can think about the use of the robotics in future. And finally, the flexible optical single incision used in laparoscopy. This method already exists and allows the removal of the gallbladder through a single incision over lateral. It is a great advance for the patient. And sorry, maybe we can imagine to have this kind of device in future for the wrist arthroscopy. So to finish, keep in mind the different society dedicated to the wrist surgery. The EWAS became IWAS. We have the ASEAN Pacific Wrist Association. Our colleague from Latin America created months ago the Latin American Wrist Association too. There is the International Wrist Centers, which is a group of society, a group of place where the possibility to treat the wrist in a modern condition with the scope is developed, and which offer you a lot of fellowship. Recently, the IWC Academy group, which is a group of teachers from all over the world, and we are developed EACAD Rwanda. The first course will be in October, the EACAD China in next May, EACAD USA probably in 2 or 5, and we're in discussion in India, maybe Oman, maybe other country. So it means that we are all together, and the most important is we have to stay all together. Could you imagine that when we started 20 years ago to develop this kind of society? We are people from all continents, and I would like to congratulate a lot Lucian, Lion, Makovici, and Alam Hanaut. We developed the World of Wrist by WhatsApp, because we are now more than 1,000 surgeons with exchange of cases, incredible cases. So keep in touch, stay together, and do not hesitate to share our information and your problem, and go to train in the different center. Friendship remains the key word of our relationship, and we have to keep that together. Thank you, everybody, and thank you every senior guy in the field of wrist arthroscopy.
Thank you very much, Prof. Prof, you can stop sharing.
Okay, thank you. Up.
Thank you very much, Professor, for this detailed presentation.
Thank you very much.
And Professor, can we have a few questions?
Absolutely.
Prof, what is the recurrence rate after ganglion excision using wrist arthroscopy? Has it declined from the conventional ones?
Okay, so at the beginning, you know, it's a very interesting question, because at the beginning, the people said that there is no recurrences after the use of the wrist arthroscopy. It seemed a little curious. I published a paper in Arthroscopy a long time ago with one of my fellow, Sabrina Gallego, who lives in Colombia, about 114 cases with more than 2 years of follow-up. It means you have to wait to see if there is recurrences. And in fact, it's exactly the same level of recurrences as open procedure. It's 10%. So when you have to perform the ganglion removal by wrist arthroscopy, you have just to inform your patient that you have the possibility to have in 10% of cases. But the simplicity of the technique, I promise you, is outpatient basis, only 2 when it is a painless ganglion, of course. When you have a painful ganglion, take care, is another pathology. But when you have a cosmetic painless ganglion, 2 small approach, no stitches, only mid-carpal, 10% of recurrences. In the recurrences, I had 9 of the 11 patients decided to be reoperated, and I never had a new recurrences after that. The 2 others decided to keep the ganglion.
Thank you very much, Prof. Prof, we are also joined by Alam Alam Arnaut is a specialized wrist surgeon from, of course, Paris. Alam, welcome to the show. Any questions to Professor, please?
Thank you. Thank you for the lecture. My first question would be a question everyone wonder about. What would be your advice for the beginners? Because we have seen the learning curve is very important for wrist arthroscopy, and the rate of complication decreases significantly with the experience. If you have to give one advice about the ideal procedure to start with for the beginners, it would be the stiff ganglia removal, the TFCC, the wafer. It is a difficult question to answer.
No, it's not a difficult question. It's a very interesting question because it is the essential problem. When you see the result of this survey, you have to keep in mind that the surgeons who participated to the survey were pioneers. So you imagine the level of complication of the first guy who performed spine fixation, for example. It was a disaster. So in fact, now it's better and better. Why? Because you have different place to learn, because the companion age is, of course, the best way to learn the surgery. The second thing is the course. The wrist arthroscopy course on cadaver is, until now, the best thing we can organize. We have a lot of courses everywhere in the world. I'm in charge personally to 20 courses a year. So it means, every month you can find a course everywhere in the world. It's very easy. And it's very important because at the end of the course, you can start the wrist arthroscopy. It's very important. When you perform the wrist arthroscopy course at the end in IRCAD, at the end, you can start the wrist arthroscopy with the ganglion removal, the wafer, the steroidectomy, suture TSCC, suture of scapholinate. It's not so bad to start. After that, you're experienced. And the last thing, very important, is to visit colleagues. When I decided to, because I started the wrist arthroscopy a long time ago with Philippe Safar, but we used a knee scope. So you remember the size of the knee scope and the size of the wrist. We created some disaster sometime and we decided to stop, and we waited for the new scope. And when the new scope arrived on the market, pushed by Alan Gilbert, I decided to come back to the wrist arthroscopy. And before, I visited some friends, Bill Geisler, Lorenzo Pedazzini, Luc de Smet, Tommy Lindo, and all these guys developed different techniques from the suture of the TFCC, the wafers, scapholinate, etc., etc. And I come back and I developed my own technique and change, etc. So to visit the guy is very essential. And the IWC group allows that. And it's very important because you find on the website the international wristcenter.org. You can, but with IRCAD, IWC.org, you have all the information and all the link with all this society. It's very simple to keep in mind. And you have the different possibility, and every week we receive demand from a colleague, from etc., etc. Last day I received a colleagues from Russia who would like to go to the Beijing center. So I make the link, and it's very incredible. So it's very essential. So companion age, better and better, cadaver course, and visit and fellowship.
Thank you. After I have just a very last question. We have seen we evolved a lot for the equipment and the indication. We are pushing more and more the indications now. What would be the field, the topic we haven't resolved yet? For example, the scapholinate instability. In which way should we focus for the research now? We have seen the stem cells, replantation. What do you think about the future of?
Yes. The future is, of course, to continue and to ameliorate the principle our techniques. So maybe there is different parts. It's a development of better device, different material to help us in the scaffolding non-union, for example, for the scapholinate suture, and a lot of techniques are described now to ameliorate the technique, the principle I described a long time ago, and of course the big challenge, I think, the big challenge is the arthritis problem arthroscopically, and I'm convinced that the Arthrocard PRP technique developed by Lorenzo, but also the development of stem cells. And I have the chance to have a laboratory of stem cells in Andorra, where I live a part of my time, created by one of my friends. And I'm going to push them to work in this direction, because I'm sure that the stem cells is a great thing, and nothing is better than the arthroscope to perform this kind of procedure.
Thank you.
Thank you, Alam. Alam, we also joined, and Prof, we also joined by Loy. Loy Al-Khatib is an orthopedic sports surgeon based in Dubai. Loy, welcome to the show, and your questions to...
Good evening, guys. Thanks
Hello,
again for that. Hi, Ahlam. Good to see you again.
How are you doing?
Good, fine. I see Ahlam asked the question that I was intending to ask about the learning curve, especially for the beginners. I don't have any other question, to be honest, to ask in this webinar. I think you covered most of the points, the important points that we need to know in hand surgery, or arthroscopic hand surgery. So then the bottom message: if we have a ganglion, symptomatic ganglion, let's say, would you use a scope, or do you go for many open technique to remove it, taking consideration the cost-effective factor?
Of course, arthroscopic technique, of course, no discussion. No, but yeah, you know, you're right. That is the problem. The question is it necessary to treat a painless ganglion? One of our partner, Mathoulin, has a ganglion for more than 20 years, and she never treated it, and she is perfect. She continued to operate. But the problem is this kind of ganglion is a cosmetic aspect. You know, finally, you can use injection, aspiration, etc. It doesn't work because you have a lot of rate of recurrence. So at the end, you have to remove it. And I know that with my daughter and my wife. At the end, I have to remove the ganglion because they didn't accept to have a ball on the wrist. So of course, when you have that, the best technique is arthroscopy. It's the same rate of recurrences, but is cosmetically there is the best option, of course.
Can I just
very, very simple? Yes.
Can I just add something? I think Loy was also talking about the symptomatic ganglia, and it's
okay. Well,
not the same story.
Sorry. It is another option.
Yes.
Every time you have a painful ganglion, take care. Because it means that there is something else. And, you know, a lot of colleagues call painful ganglion. There is no the ball, cosmetic ball. There is on MRI an aspect, and your radiologist told you it is a dorsal ganglion. Every time you have a painful ganglion, take care. It's very often another problem. It's either a scapholinate dissociation or a real ganglion. It exists, a very small ganglion surrounding the DCSS, and because there is a hyaluronic acid inside the ganglion, they hit, as for the knee ligament, they hit the ganglion, and it is the first step of the scapholinate instability. So every time you have a painful ganglion, take care. MRI is a minimal exam you need, and arthroscopically you have to enter radiocarpally by radiocarpal and midcarpal approach, and to check everything, and sometimes you have to perform a suture.
Awesome. Thanks a lot.
Professor, do you have any specific contraindications for wrist arthroscopy? For example, suppose that you have planning to do a ganglion excision and the patient has some sort of a mild or a moderate level of carpal tunnel syndrome. So do you think an associated neurological disease is a contraindication?
Now, for me, no. For me, no. Yeah, there is no real contraindication. Only one. Only one is, but it is a mechanic contraindication. You need to create a distension, a traction, in order to create a space, because the space doesn't exist in normal life. It's why you have to create a contraction and a traction, axis traction in your hand. So if you don't manage to obtain that because there is a big stiffness or there is a special attractive, something like that, don't try to enter. You create damages. So the only contraindication, and if it's a mechanical contraindication, if you don't manage to obtain a real space, don't try to enter. It's too dangerous.
And of course, even when you have a tumor as well, right? Suppose you have a GCT of the distal radius. That's again a contraindication, isn't it?
Distal radius to your fracture. I mean, no, it's not. It's an indication.
GCT, a giant cell tumor of the distal radius.
Giant tumor. Yes, it's interesting. I have never faced in front of this kind of. I think about, yeah, why not? Yeah. I think you can, every time you have the space to put a scope and to check, you can do it. You can go. It doesn't mean you manage to do something interesting, but you can go to see. And if you can, why not? But normally the giant tumor on the distal radius, you don't need to go inside the joint.
Exactly. Thank you. Any more questions, Alam and Loy?
Not for me. It's vertic is okay. Thank you.
Thank you, Professor. That's all the questions that we have for this session. Thank you for this fantastic talk. And we really look forward for more from you. Thank you so much.
Thank you very much.
Thank you.
Have a good afternoon.
Professor.
Bye.